include 1 hour credit for Category 1 AMA Physician CME and 1 hour credit for Virginia Nurses Association CEs. Sovah Health is accredited by the Medical Society of Virginia, a member of the Southern State CME Collaborative, to provide ACCME or AMA Physician CME. Similarly, Sovah's is accredited by the Virginia Nurses Association for nursing CEs also. The program tonight was developed in order to promote two desirable physician attributes, which include our providing patient-centered care and always employing evidence-based medicine. As far as commercial relationships of either of our program faculty this evening, Dr. Liu reports that he served as a consultant at some point during the past 2 years for Lucent, and he's nicely agreed to mitigate this relationship by providing his slides for a CME review, which we did, and they do not have any evidence of commercial bias, and attesting that the recommendations he made are all coming from evidence-based medicine, free of any commercial bias, usually from peer-reviewed literature or basically consensus-generated guidelines. Dr. Walsh, myself, and the members of the Sovah Health CME committee, which assists in developing our programs, as well as our program coordinators, have nothing to disclose as far as commercial relationships. There is no commercial support for this program this evening. It is supported, like all of our CME programs, by an educational grant from the Ralph Landis Medical Education Fund that resides at the Danville Community College Educational Foundation. Excuse me, Dr. Landis, the founder of our local Southside Urology Clinic, previously known as the Danville Urology Clinic, created this fund upon his retirement, and it has served as an endowment that allows us to support continuing education for all types of healthcare professionals in our community. This evening, after the program, you'll receive by email an evaluation form. We'll ask you please take a few minutes to complete that and send it back to us electronically. It requires two things, your answers to a number of questions. Among those is the fourth question, which asks, what will you be changing in your practice based on what you learned this evening? And that's for everyone, not just for the physicians on the call. We all practice our healthcare skills based on our scope of practice. Take a few minutes, tell us what you'll be changing as you go forward. Also, be sure that when you fill out the information on that eval form, which asks you to re-enter your email and name, please give us your full name, no nicknames or short names, and as much as the name you enter will be what will be on your CME certificate of your attendance. That certificate will come to you electronically once you submit the form. The eval forms are not required of physicians to receive credit, but they are required of nurses and nurse practitioners to receive CE credit. So if you will, be sure and take a few minutes, fill out the form. In addition, another way you can access the form is you'll see a QR code in the chat box at the end of the program, which will take you directly to the same eval form. You don't have to do two, but whichever mode you like best is just there to make it a little easier for you. For the many residents on the call this evening, you do not have to keep up with your CME certificates. Your program coordinators, Darren Johnson and Lori Galvez, track those for you. I like to also just, every time we do a program, take a moment and thank Mary Kent, the CME coordinator, and Jennifer Goodman, our nursing educational coordinator, for their help in our arranging this program this evening. They do all the, if you will, heavy lifting in the back room of the documentation and the needed accreditation things, and I'm very grateful for their help and their support. I know that Dr. Liu and Dr. Walsh both hope you'll have questions and comments. This is really your chance to talk to experts on the area of dementia. When you do make a question, you can raise your hand and it'll be funneled to Dr. Liu or Dr. Walsh during the program. Or if you want to just speak up, that's fine too. Once you've stated your question verbally or orally, please mute your phone to hear the response so it reduces the feedback we get. You're also welcome to do more than one question or comment. The more discussion we have, many times it's a tremendous enrichment to the overall program. I want to highlight for you very briefly two programs we're doing in July. We normally have not been doing programming in July and August because so many people are away, vacations and so forth, but we had two pressing matters. One is the current increasingly prevalence of measles throughout the nation as well as internationally. And we thought this would be a really good time to have Dr. Jeffrey Donowitz from Virginia Commonwealth come and update measles diagnosis, how one manages it, although a lot of it's empirical. And just as important, if not more important, is how you can, as a provider, deal with resistance of patients or families to actually have vaccination, in this case to measles. And then on Thursday evening, July 31st, we're having a very special program. We really want to try to provide help to all healthcare providers in helping their patients find necessary services in our two communities, Danville and Martinsville. So Mrs. Molly Huffman, who is a well-respected healthcare attorney in Richmond, is going to talk with us about how to determine mental capacity to make healthcare decisions, which enters into how patients choose where they will be receiving their care. And then Dr. Brittany Lewis, one of our senior Sovah Health Family Medicine residents, has spent quite a bit of time on, if you will, indexing and organizing the local patient resources for both communities. So I hope you'll be able to attend either of those programs. We'll be sending out our usual announcements. All that being said, I'm delighted that Dr. Francis Walsh, one of the Martinsville Sovah Health campus neurologists, has been generously agreed to serve as our moderator tonight. Some of you know Dr. Walsh well. I have known him and enjoyed knowing him for a number of years. He's a member of our CME committee. He received his undergraduate degree from Harvard, graduating cum laude, followed by medical school at Wake Forest, then known as Bowman Gray, with his residencies in neurology at the University of Massachusetts, UMass as it were. He returned to Martinsville, where he chose to practice, as he talked to us earlier on the call tonight, wanting to raise his family in a small community. And we are so fortunate to have him, having spent his career with us in Martinsville. That being said, Dr. Walsh, I'll turn it over to you. Dr. Lou, if you want to bring your slides up, mine will follow. Thank you both so much.
All right.
Thank you, Mike. I'm Dr. Frank Walsh. I'm at Martinsville Neurological, and as Mike said, part of the Sovah Health System. I just came back from the CCU doing a spinal tap, so I'm glad I was able to make it in time. Tonight's my pleasure to introduce Dr. Andy Liu from Duke. He's going to give us a talk on dementia and other neurodegenerative diseases, period. He is the associate professor in neurology and pathology at Duke. He did his residency training at Yale Medical Center, a fellowship at UC San Francisco as a clinical behavioral fellow. And in the neurology world, UCSF is the place for behavioral neurology. He is board certified in neurology and behavioral neurology and neuropsychiatry. He has numerous presentations and publications, and he's going to talk about the neurodegenerative diseases, especially the dementias. And I use the plural because there are a number of them. I'm sure it'll be a very informative lecture. And with that, I'm going to turn it over to Dr. Liu.
All right. Thank you for the introduction. The title of my talk really is The Clinical Characterization or Phenotype of Various Neurodegenerative Disorders or Dementias. And I just want to remind everyone out there that if there are any questions throughout the lecture, please feel free to stop me at any time. I'm happy to answer them. So now, before we get started, I wanted to disclose my funding and any relationships. As Mike said, I am a consultant for Lucent, which does not impact today's lecture at all. And these are some of my fundings as well. In terms of the outline of the talk, I'm going to talk about the neuropathology. The neuropathology is something that clinicians really don't deal with a lot, but at UCSF, that's really what I was taught to kind of think about the neuropathology, because that's what drives all the clinical phenotype, the symptoms, and kind of knowing that briefly will help you kind of distinguish different types of neurodegenerative syndromes. I'm going to define dementia. I'm sure many of you out there already have that question as, what's the difference between Alzheimer's disease and dementia? That's probably the most common question that I get still in the clinic. I'm here to kind of disseminate the difference, and you guys can pass that on as well. I'm going to talk about the non-Alzheimer's disease dementias, really two forms, frontotemporal dementias and the Parkinsonian syndromes. Those are the two most common forms of non-Alzheimer's disease dementia that we see in the clinic. Then I'll move on to Alzheimer's disease dementia in and of itself, and then when to refer to the Duke Memory Disorders Clinic, and lastly, clinical trials. So to start off with the neuropathology, I want to talk about non-Alzheimer's disease neuropathology. It's really kind of two main categories: frontotemporal lobar degeneration, FTLD, and Parkinsonian syndromes. And so I want to first start off with frontotemporal lobar degeneration. I want to step back, though, and kind of at least mention we use FTLD when we're talking about the neuropathology. When we're talking about clinical syndromes, we talk about FTD. So if we're talking about only the clinical presentation of the behavioral variant of frontotemporal dementia, we call it FTD. If we're talking about the proteins that are causing that FTD, we then switch over to FTLD. That's kind of a nomenclature in the field that I want everyone to be aware of. But in terms of FTLD, there's really two main categories. And then I think there's one that's less known. So TDP-43 is the most common form. There are different subtypes, A, B, and C, and they're only distinguished by under the microscope morphologically. There's one called FUS, which is the very rare one that we very rarely see. And then another one that I'll talk about in a minute that is kind of here that belongs to tau. On the other side is Parkinsonian syndromes, and that really involves alpha-synuclein, which makes these Lewy bodies, these dark circles that you can see here. We now call them collectively as neuronal synuclein diseases, because Parkinson's disease, dementia with Lewy bodies, and two other disorders all have the same protein. It's just building up in different parts of the brain, which is why they really present very differently, but it's all the same protein. And then last one is the tau, as I had mentioned earlier. So this one here on the left shows Pick's bodies. So a lot of tau in neurons, and that's where the Pick's disease was first described more than 100 years ago. And then on the right panel, this is something from progressive supranuclear palsy. So another tauopathy, if you will, where they have glial cells such as astrocytes and neurons that are collecting this tau protein. Now I want to at least mention the neuropathology of Alzheimer's disease, which really dovetails into the amyloid hypothesis of AD or Alzheimer's disease. Very briefly, I will talk about kind of the biochemistry of amyloid and how it gets out of the cell. First off, you can see APP right here is amyloid precursor protein. It is first cut by this protein called base 1. It then is cut again by this gamma secretase, and the C-terminal fragment stays in the cell. All of these A-beta monomers are within the endosome and gets transported out of the cell. Therefore, amyloid continues to build up as monomers, fibrils, protofibrils, and then eventually extracellular plaques. They cause the hyperphosphorylation of tau. They also cause synaptotoxicity and decreased capillary blood flow. As the disease kind of progresses, you can see in this diagram here how it accumulates and where. So the red is the amyloid, and as you can see, the lateral parts of the brain aren't as heavy hit as the medial parts of the brain shown in this column. So the red kind of parietal lobes, specifically the precuneal areas, and the frontal lobes called the orbital frontal cortex are first affected. And as the disease progresses, it will continue to engulf those areas. The blue shows the other protein in Alzheimer's disease, which is tau. It primarily stays in the temporal lobes and then goes posteriorly to involve the entire temporal lobe, which leads me to show you this. So tau is, I think of it as kind of a zombie protein. So the misfolded tau seed is the zombie protein. It interacts with normal proteins and causes them to misfold as well. And then they start to aggregate these paired helical filaments known as neurofibrillary tangles, which are inside the cell. They are then transmitted transsynaptically to neighboring neurons where they continue to propagate. And this is important because tau is the one that correlates most closely with symptoms. The accumulation of A beta usually does not cause a lot of symptoms. And I say that because about 20 to 30% of 80-year-olds out there have amyloid, but they are completely asymptomatic. So this, if you see someone in the clinic, and they're symptomatic, they probably have a lot of tau already in the brain. Now, I'd like to at least show you kind of a map of all the biomarkers within the central nervous system shown right here. So you can see that this thing with this myelin is the neuron, and then there's different cells called the astrocytes, and then the vascular units and the amyloid plaques. And this kind of just illustrates where we've taken all these blood biomarkers. You can see there's synaptic biomarkers here, biomarkers from the axon, so on and so forth. So it's a good diagram to kind of picture and visualize where all these biomarkers are coming from, which will be important later on. Now I'd like to talk more clinically about what is dementia. So in the clinic, every time I see a new patient, what I'm trying to do first is to determine their cognitive status. So in any neurodegenerative disease, they continue along a spectrum between normal cognition and dementia. All four of these categories can be distinguished by three specific characteristics. Normal cognition is pretty straightforward. It is normal across the board. The cognitive testing can be anything that you prefer. The SLUMS, I use the MoCA, the MMSE, anything that you use that is standardized. So ADLs and IADLs really represents the functional status of a patient. So ADLs represents activities of daily living, and IADLs are instrumental activities of daily living. So IADLs are more complex tasks, driving, medication management, financial management. ADLs are kind of more basic. So bathing, toileting, dressing, feeding. Are they able to do all of that on their own? For the most part, all of these diagnoses, they're able to function completely independently. It's only when people are in the dementia stage when they're not able to. So that's what I tell patients when they ask, what's the difference? Does my mom or dad have dementia or Alzheimer's disease? And so what I tell them is dementia is a clinical term. It just means that they have brain function problems that are severe enough where they can no longer safely live alone. That is it. It does not tell us the cause. It's like saying you have a cough, and I'm not telling you what the cause is. Alzheimer's disease is just the most common form of dementia. It accounts for 70 to 80% of all dementias. So that's kind of how I see it when I initially meet someone. And the SCI, subjective cognitive impairment, and mild cognitive impairment groups, very similar. The only distinguishing factor is in cognitive testing, SCI patients score normally, whereas mild cognitive impairment patients do not. Now, moving on to the non-Alzheimer's disease clinical syndromes or presentation. I want to first talk about frontotemporal dementia, and as I mentioned before, because I'm talking about the clinical syndrome, I call them FTD. So FTD was previously called Pick's disease. It's an antiquated term that really described one of the frontotemporal dementias that I'll talk about here in a second. We now know Pick's disease only accounts for about 20% of all FTD cases. Is there a question out there?
But if you're trusting in Jehovah, because our decision.
All right. Well, if there's a question, let me know. So with frontotemporal dementias, there's three different subtypes. The behavioral variant frontotemporal dementia, BVFTD, the non-fluent agrammatic, NFV PPA, primary progressive aphasia, and the semantic variant, primary progressive aphasia, SVPPA. Pick's disease was this last one, the semantic variant, and it only counts for about 20%. The lion's share, about 60%, is the behavioral variant. So this is the one everyone thinks about in terms of the person that acts very bizarre. And I think a good way to think about it is with FTDs, especially the behavioral variant, when people have these symptoms, people start to shy away from them. They lose a lot of friends because they're acting so bizarrely. Whereas in Alzheimer's disease, in contrast to that, Alzheimer's disease, because they lack the insight and they have cognitive symptoms, a lot of close family and friends kind of try to gravitate and support them a little more. That's a big kind of clinical distinction that I see between the two disorders. Now, moving on to Parkinsonian syndromes, the one I'm going to talk about tonight is dementia with Lewy bodies, DLB. There's other ones called Parkinson's disease, of course, multiple systems atrophy, pure autonomic failure, progressive supranuclear palsy, and cortical basal syndrome. This red rectangular box really illustrates the four that accumulate the alpha-synuclein protein. The other two, PSP and cortical basal syndrome, accumulate the protein of tau. However, because they all have movement disorders, they're seen by the movement disorder specialists traditionally. Now, moving on to the epidemiology of FTD. So FTD has an average onset that is much younger than a lot of the neurodegenerative conditions, which is a distinguishing factor. So around 58 years old. So I typically think about people in their early 50s, late 40s, all the way up to late 50s for frontal temporal dementia. Men and women are equally affected, and about 3.5 cases per 100,000 people are seen or diagnosed each year. Now, in terms of BVFTD, it's really a progressive deterioration of behavior and or cognition reported by a loved one. They usually do not see this as an abnormality themselves. They display disinhibited behaviors, and what I mean by that is if you and your friends go out for a few drinks and one of the friends starts to act a little more unhinged, that is disinhibition. Okay, so just remember that. That is what a patient would do just completely on their own. They also have early apathy, which means they just have no drive to do anything. So they just sit there and kind of watch TV all day. Early loss of sympathy or empathy. You know, if a loved one is hospitalized and someone asks about them, they kind of shrug it off, thinking it's not a big deal, which is a big change for that person. And then early perseverative or stereotyped compulsive ritualistic behaviors. I've had patients who just sit in front of me and they're fiddling with their watch. They're taking it on and off the whole time. They're taking their glasses on and off. They're messing with their hair. That kind of very stereotyped motor function without a purpose is what I'm talking about right there. A lot of BVFTD patients also have hyperorality and dietary changes. So people who start to kind of narrow their diet to primarily sweets and carbohydrates, they gain a lot of weight. That could be a sign of BVFTD. I had a patient who really restricted himself to only shrimp. So his kitchen was just littered with shrimp tails. And then on neuropsych testing, executive function is the predominant thing over memory and visual spatial function. So those are the 6 criteria. I don't expect you guys to know all 6, but if you see 1 or 2, feel free to send down to the Duke Memory Disorders Clinic for me to evaluate further. Same thing goes with the primary progressive aphasias. You know, the definition of an aphasia is the expression or understanding of a speech due to brain dysfunction. So it can't be a laceration of the tongue or their jaw is wired shut. It has to be something higher up. Now, the inclusion is the first symptom has to be language. That is the most prominent thing. So that it impairs their ability to live independently. So they fulfill that dementia criteria. For example, if I had a language disorder that prevented me from giving this lecture, that would be a primary progressive aphasia. Now, exclusion criteria include another neurodegenerative condition or a psychiatric diagnosis. I put the criteria up of the different types of primary progressive aphasias, not for you to memorize, but just to know that there are specific criteria to make these diagnoses. Again, if you see 1 or 2 of these, feel free to send down to Duke, and I'm happy to characterize a little further. Now, the genetics of frontotemporal dementia are well known. So there's common genetic mutations, really three that stand out and are commonly tested. The first one is GRN or progranulin. Second one is called C9 open reading frame 72, or shorthand is just C9orf, and then MAPT, which is the microtubule associated protein tau. So that is the gene that leads to the expression of tau. Those are the three that are most commonly seen in the genetic forms of frontotemporal dementias. Now, in terms of imaging, it is supportive of the diagnosis, but it does not make the diagnosis. Sometimes people come in saying, oh, there's a PET scan that has decreased metabolism in the frontotemporal regions. It's got to be FTD. That can be supportive, but there are other things that can cause that kind of imaging result as well. Now, as you can see here, from the initial visit for my patient, for those that don't see MRIs that frequently, the face is here at the top of the screen. The bottom is the back of the head. The right side of the image is the left side of the brain. And so the left side of the image is the right side of the brain. And you can see that there's a lot of atrophy of the right lateral, medial, and anterior temporal lobe, as well as the frontal region called the orbital frontal cortex. You see this black line that's not usually there. We fast forward 3 years later, you see progressive atrophy of that right temporal lobe, more atrophy of the orbital frontal cortex, and now there's a lot of atrophy of the left temporal lobe. And that's actually very common. After 2 to 3 years, that atrophy will swing over to the other side. And for the clinicians out there, it's really important because you can actually predict what might happen going down the line with BVFTD patients. I usually tell patients 2 to 3 years, if you start having kind of behavioral variant, you're going to start having language problems 2 to 3 years down the line. That's why it's useful. Now, in terms of the other PPAs, radiographically, for the non-fluent agrammatic, you can see here that there's a lot of atrophy in the white matter right there, and then the peri-insular area, as you can shown by the arrows. My patient with a semantic variant primary progressive aphasia has a lot of atrophy of the anterior left temporal lobes. Now, FDG PET, as I said, sometimes it can be confounding, but it is supportive at times as well. So in this top row, the non-fluent agrammatic variant shows hypometabolism, shown in this purple, in the frontal and temporal lobes, as shown in the MRI too. And then with the semantic variant primary progressive aphasia, you can see that the left anterior temporal lobe is more affected than the right. Okay.
Lou, can
Yeah.
you explain how would the semantic variant present?
Yeah, so the semantic variant is pretty simple, actually. So the semantic variant means you lose semantic knowledge. So for the trainees out there, when we're testing people's with naming, you're actually testing that left anterior temporal lobe. So you say, what is this? You're pointing at your pen. What is this? You're pointing at the watch. People with the SVPPA, they will have no background knowledge of that. So when you point to it, they will have no idea what you're talking about. I had patients who would present and the wife would say, oh, I would ask my patient to go get the mail at the mailbox. And then the patient would just give kind of a blank stare, not knowing what a mailbox was, so that loss of common knowledge associated with words is gone in semantic variant primary progressive aphasias. So that's kind of how they would present right there. And then the non-fluent variant, I can touch on that real quick as well. Those are the people that look like they have a Broca's aphasia. It's like they're trying to really effortfully give a speech or trying to put out those words, finish those sentences. Those are the people with the non-fluent agrammatic primary progressive types. So it can be tricky. Sometimes there's an overlap. It can be even more tricky because Alzheimer's disease has a primary progressive itself called the logopenic variant. And that's where the behavioral neurology training goes in to help us distinguish that. It's especially important now because we want to know those people with the Alzheimer's disease form, the logopenic variant, they might qualify for the anti-amyloid therapies, whereas with the primary progressive aphasias from frontotemporal dementias, we don't have a disease-modifying therapy at this time. this dovetails really well into the treatment. For frontotemporal dementias, currently it is supportive. The guiding light is maintaining their quality of life. So medications that help control the behaviors of the BVFTD, speech therapy for primary progressive aphasias. And what I've learned is that a medical ID or a bracelet is incredibly important for primary progressive aphasia patients. Because as you can imagine, if they're on a walk and they have suddenly have a sudden change and they want to talk to someone, someone who doesn't know them might think they're having a stroke. So having that medical ID or bracelet that says this is a neurodegenerative condition, otherwise they're whisked off to the local hospital and a stroke alert is started and they go through a lot of unnecessary testing. Now I'm moving on to another one, the Parkinsonian syndrome called dementia with Lewy bodies, and I'm going to talk about this as well. The epidemiology of dementia with Lewy bodies is more similar to Alzheimer's disease, where the average age of onset is about 75. There's conflicting gender preference. I have not seen a specific preference in my clinic. I think men and women are equally affected, but Blacks are more affected than whites, and it affects about 5% of the general population. It accounts for as much as 30% of all dementia cases. And what I would like to say also on top of that is 30 to 50% of people with dementia with Lewy bodies also has Alzheimer's disease. We now know that because there are biomarkers that we can actually test for dementia with Lewy body disease or Parkinsonian syndromes. Now, the incidence is about 3.2% of the people who are newly diagnosed with this dementia syndrome. So the clinical criteria for DLB is these core features, but I highlight D because they really have to fulfill dementia criteria. So are there symptoms, are all of these core features affecting their day-to-day? If so, then it's dementia with Lewy bodies. Otherwise, I just say it's neuronal synuclein disease. We think it's some alpha-synuclein that's building up, that's causing some mild symptoms, but they don't fulfill dementia criteria at this time. The fluctuations in cognition and attention and arousal, that is a big one. So a lot of people think that they could be confused with delirium or seizures. The recurrent complex visual hallucinations are also very common. There's something called extracampine hallucinations where they feel like in the periphery of their vision, they see something scurrying across the floor or something up above, that a shadow is what they typically kind of describe as well. And then REM behavior sleep disorder. This is a big one as well, where it's periodic limb movements during sleep, and this can happen decades before their core features really come on too, the other core features. And then lastly is the spontaneous features of Parkinsonism, so the motor features. But what I tell patients in the clinic is that just because you don't have motor symptoms doesn't mean it's dementia with Lewy bodies. The vast majority of the people I diagnose with DLB do not have motor symptoms on initial presentation. Now, there are a lot of supportive features, severe sensitivity to antipsychotics that we're taught in medical school, postural instability. There's a lot of severe autonomic dysfunction and repeated falls because of the severe autonomic dysfunction as well. So those are things that can kind of clue you in. But thankfully, we have biomarkers now that can really help kind of parse that out much more definitively that I'll talk about the next couple slides. So the previous biomarkers criteria for dementia with Lewy bodies are as follows. So a polysomnogram that shows periodic limb movements during sleep, decreased dopamine transporter uptake on SPECT PET, and then an abnormal myocardial scintigraphy. So that just means deinnervation of the heart with the autonomic system. There are supportive biomarkers as well, preservation of the medial temporal lobes on CT MRI, because with that's more suggestive of Alzheimer's disease. There's a SPECT PET that shows something called a cingulate island sign that I'll show you in a couple slides, and then slow waves on EEG, which really kind of speaks to that fluctuation in mental status. Now, the genetics of dementia with Lewy bodies is really just one. So synuclein alpha, SNCA, but for the most part, there's not a familial kind of pattern to dementia with Lewy bodies or Parkinsonian syndrome. I now want to briefly talk about that cingulate island sign that I was talking to you about on FDG PET. So with FDG PETs, the brighter the signal, the hotter the signal, the more active the cells are. So the white signals means very active cells. And as you can see here in the control, the white signal right here in this top portion called the posterior cingulate is very active. It is somewhat active here in the dementia with Lewy body patients, and it is not active at all in the Alzheimer's disease patients. So that's what we're looking at right here. And as you can see down here in the arrow, it's pointing at that bright signal right there. That is that cingulate island sign. I have tried to use this in clinic. I sent 5 patients for this. Only one of them was positive. I don't think it's a very sensitive biomarker at all. Thankfully, we have ones that are far better. One of them that came out in 2020 is the alpha-synuclein that you can detect in the skin. And so skin biopsies for specific areas is greater than 90% sensitive and greater than 90% specific for all these neuronal synuclein diseases. Now, we detect the phosphorylated type of alpha-synuclein, and we do it in 3 different skin regions to really kind of biopsy the entire peripheral nerve. One at the base of the neck for the kind of more medial and I guess proximal parts, one above the knee for the mid portions of the nerve, and then one above the ankle for the more distal parts of the peripheral nerve. Now, this was all brought out because we thought that the skin represents central nervous system pathology. On autopsies, they found that the alpha-synuclein was in the skin before it was in the brain, which is where the skin biopsy came from. And the pattern from the Gibbons paper last year really helps kind of determine what type of alpha-synuclein protein is going on. So the skin biopsy to detect this phosphorylated alpha-synuclein in Parkinson's disease, dementia with Lewy bodies, MSA is multiple systems atrophy, and pure autonomic failure. So the bigger the circle, the more likely it's going to be positive. So as you can see, dementia with Lewy bodies is pretty much equal in the first 2, but then more distal portions is less so. And these arrows show kind of small fiber neuropathy, which is more common in dementia with Lewy bodies as well. Now, in terms of the sensitivity and specificities of the skin biopsy, overall, for all neuronal synuclein diseases, the sensitivity is almost 96%, and the specificity is almost 97%. With all specific neuronal synuclein diseases, as you can see, everything is above 90%. The lowest, surprisingly, was Parkinson's disease. Now, I definitely want to mention cerebral spinal fluid biomarkers of alpha-synuclein, something called seed amplification assay, SAA, for Parkinson's disease. The sensitivity varies between 86 to 96%, but it is very specific. Seed amplification assay is just the renaming of real-time quake-induced conversion, otherwise known as RT-QuIC. And so it goes back to that zombie protein kind of hypothesis where abnormally folded proteins come in contact with normal ones, cause them to be misfolded as well, and then it propagates from there. Of course, with the CSF, it's a little more invasive because you have to do a spinal tap, but with Alzheimer's disease biomarkers these days, you could do both at the same time. The only reason I don't do this is because multiple systems atrophy has a misfolding that is hard to detect with the seed amplification assay. The sensitivity is probably 70s to 80% compared to the skin biopsy, which is above 90%. Now, for the treatments, there's no disease-modifying therapies at this time, but we do know that there's a significant cholinergic deficit in dementia with Lewy bodies and many of the alpha-synucleinopathies. So especially with dementia with Lewy bodies, I start them on rivastigmine. That one was the one that was studied several years ago. The maximum dose is 12 milligrams PO, or you can do a 13.3 milligram patch if they can't tolerate the PO. You do have to manage some of their behavioral symptoms as well, specifically the kind of fluctuations in mental status and visual hallucinations. I'm going to transition now to the most common form of dementia, which is Alzheimer's disease. I want to describe the clinical syndrome of Alzheimer's disease. A lot of people know the amnestic presentation, which is usually in the older population, so the late onset Alzheimer's disease. I want to briefly talk about the early onset Alzheimer's disease. This can be tricky. So these patients are below the age of 65. So when they fulfill dementia criteria, they're below the age of 65. So someone can come in at the age of 67, but they've had clinical symptoms that started 5 years ago. I would still consider them as early onset Alzheimer's disease. And I point this out because they have different presentations. They have the language variant. They have the behavioral variant that looks like frontal temporal dementia. They have visual spatial variants, also known as Benson's disease, So it can be tricky, and sometimes they have to go to multiple clinicians before they get the final diagnosis. And it occurs in 22 to 61% of all patients. Now, a lot of early onset Alzheimer's disease patients also have an amnestic syndrome as well. But just beware that the early onsets have a different presentation, and they go much quicker in terms of the disease course. In contrast to the late onset, that's the more traditional one a lot of people know with memory loss. And then it can continue to progress. But if there's another disorder such as dementia with Lewy bodies, they go much faster as well. Now, the genetics of Alzheimer's disease is definitely well studied. The most common one is APP, amyloid precursor protein. This is on chromosome 21. So people with trisomy 21 have that extra copy of APP, which is why they almost invariably develop Alzheimer's disease in middle age. We have the BACE1 gene as well that can cause a familial form of AD, along with presenilin 1 and presenilin 2. My presentation would not be complete if I didn't mention ApoE, since it was also discovered here at Duke, which is the most common risk factor for the development of Alzheimer's disease. And so anyone who has at least one copy of the E4 allele is at higher risk for developing Alzheimer's disease. If they have two copies, I think the Thor actor, he actually revealed in his Netflix documentary, he is an ApoE4 E4 carrier. So he is 15 times more likely than the general public to develop Alzheimer's disease later in his life. Now, in terms of the diagnostic criteria, I want to at least mention that the diagnostic criteria was updated last summer from this paper by Clifford Jack at the NIA and the Alzheimer's Association, where you actually no longer need clinical symptoms to make the diagnosis of Alzheimer's disease. All you need are biomarkers. And this paper shows this table 1, and it has all these biomarkers that you can look at. What I would do is I wouldn't focus on the IVS right now. That's not as important. The A, T, and N is the most important ones. A stands for amyloid, T stands for tau, N stands for neurodegeneration. And we make that ATN designation because we believe that's how the amyloid hypothesis starts. Amyloid starts to accumulate, tau then accumulates, and then neurodegeneration. So now with this criteria, there's core 1 biomarkers. So very early pathology that occurs with A beta accumulation extracellularly, making those plaques, or the tau based on p-tau 217, 181, and 231 in CSF or plasma. If either one of these are positive in this fluid, they automatically are diagnosed with Alzheimer's disease. If you do amyloid PET imaging, they are also, and that's positive, they are also diagnosed with Alzheimer's disease. The p-tau 217, 181, 231, that number just means the phosphorylation site of the protein. So at amino acid 217, it's phosphorylated, so on and so forth. They make a designation of core 2 because these proteins in the fluid, CSF or plasma, which is MTBR243, p-tau 205, or non-phosphorylated tau in the mid regions, these come on later in the disease course, which is why it's considered core 2. Tau PETs are also positive later in the disease course too. We can use NFL in the plasma to determine neurodegeneration, as well as an MRI or FDG PET. So that's kind of the update in terms of the diagnosis of Alzheimer's disease at this time. Now, this is another overview of Alzheimer's disease biomarkers. So this just shows a neuron, vascular unit, and other glial cells, and what they excrude and how they get into the CSF. So A beta, extracellular A beta plaques in the CSF, p tau, NFL, and GFAP. And it will transfer into the cell, into the blood. But what we see for people with Alzheimer's disease is that the A beta is very low. A beta is a very sticky protein, so it will stay in the brain parenchyma and it will be low in the CSF and in the blood. In contrast to that, p tau, NFL, GFAP, they're all elevated in the sporadic forms of Alzheimer's disease. Epidemiological studies also show kind of the time course as to when these proteins are abnormal. So as you can see here in familial forms of AD, A beta 42 in CSF and plasma become abnormal first. You can then detect it later on by amyloid PET, and then p tau in CSF or plasma fluids become positive. Neurogranin, which is a synaptic marker in the CSF, becomes positive there. Tau PET, MRI, NFL, and then finally the clinical symptoms of Alzheimer's disease finally comes about. This is also shown to hold up in the sporadic forms of Alzheimer's disease as well. The only problem with Alzheimer's disease a lot of people criticized was it was primarily from a white population. However, a Chinese study last year showed that participants with Alzheimer's disease and various biomarkers shown in orange compared to normal cognition shown in blue have abnormal proteins similar to that seen in the white population. So in the CSF, these are all CSF studies except for panel F, which is the hippocampal volume on MRI. And all the patients with the Alzheimer's disease have a lowering level of A beta 42, A beta 42-40 ratio, and then total tau and p tau, NFL are all going up. The CDR, which means clinical dementia rating scale, sum of boxes, is just a standardized form similar to the MoCA, where we can distinguish people with dementia and without based on their functional status. And people with Alzheimer's disease has a high score, which means that they are more affected. Another way to see kind of the biomarkers and how they progress is this is time zero when Alzheimer's disease is diagnosed. And from this paper from this Chinese population, A beta 42 is abnormal about 18 years before the diagnosis. And then the 42-40 ratio, which we use to kind of normalize the 42, is also abnormal about 14 years before the diagnosis. And you can see the other biomarkers start to fall in line afterwards as well. Now, cerebral spinal fluid biomarkers were actually researched in the 1990s. And this is because the clinical diagnosis of AD was only about 70 to 87% sensitive and 44 to 70% specific. So not very good. So the CSF AD biomarkers that we use is A beta 42, total tau, p tau 181, and A beta 40, which is the normal form. A beta 42 is low, which is the pathologic form of amyloid beta. The 42-40 ratio then is also low because the numerator is because of the A beta 42. And again, A beta 42 is a very sticky protein, stays in the brain parenchyma, which is why it's low in the cerebral spinal fluid. In contrast to that, total tau and p tau 181 are very high in Alzheimer's disease because in the cells are dying, they're kind of extruding those proteins in the cerebral spinal fluid, which is why it's high. Microtubule binding region 243 is also kind of a mid-disease biomarker. And so that is also elevated in Alzheimer's disease patients as well. For the imaging biomarkers for Alzheimer's disease, we use amyloid PET, tau PET, and MRI. Here are some illustrative examples of an amyloid PET scan. So amyloid PET scan, as shown here by my colleague, you can really see the accumulation of amyloid in specific parts of the brain. The hotter the color, the more amyloid there is present. So in the CN, which is cognitively normal, in the A beta negative patients, you see very little hot colors. You can already see that red in the frontal lobes in the A beta positive patients. The mild cognitive impairment patients, as you can see in this middle row, more accumulation in the A beta positive, not only in the frontal lobes, but in the posterior part of the head. And then in the Alzheimer's disease, you don't see any hot colors in the A beta negative, but in the A beta positive, you see red pretty much everywhere taking over. When we see that gray-white kind of blurred, then we know it's a positive amyloid PET scan. Same goes with the tau PET imaging. So the hotter the color, the more tau there is. So in the controls, this top row shows the lateral parts of the brain. In the controls, it's just purple everywhere. You can see a lot of hot colors, primarily in the temporal lobes on both sides, more on the left than the right. When you look at the mid-sagittal regions, no tau there, but in the Alzheimer's disease patients, a lot in the precuneal regions shown in the red right there. The MRI brain, this is a patient of mine that we color coded with a software to kind of quantitate different areas. Mustard color is the hippocampi. As you can see, it's very, very small in the coronal planes. When we look at the axial planes, very little hippocampi are left right here, which is very, very commonly seen in Alzheimer's disease. If I go further back in the parietal lobes, you would see a lot of atrophy in that region as well, which is common in Alzheimer's disease. Now, moving on to the most exciting part of biomarkers for Alzheimer's disease, which is the blood-based biomarkers, BBMs. So in 2011, the first A beta 42 plasma level was finally reported. 2 years later, the total tau was able to be detected. A year after that, 42 and 40 detection was possible. In 2017, the phosphorylated tau 181 was detected, and in 2020, this is a large moment for the field where phosphorylated tau 217 was discovered and is now pretty much everywhere. I'm sure many of you out in the audience have heard about p-tau 217 and might be using it at this time. Now, plasma AD biomarkers have varying sensitivity, is between 62 and 97%, because some people use kind of mass spec and some people use immunoassays. So depending on what you use, mass spec is more sensitive, but I think immunoassays are a little easier to run. So there's a kind of a balance between those two factors. We can do p-tau 181, 217, and 231, but p-tau 217 is clinically available. I see it quite frequently now in the clinic, and that's because the sensitivity is almost 100%. Now, in terms of other plasma biomarkers, total tau and NFL are present, and I don't think I see a lot of total tau, but NFL is there. These biomarkers are sensitive but not specific. I say that because total tau can be elevated in other neurodegenerative diseases such as CJD. NFL can be elevated in frontotemporal dementias. So it's not specific to Alzheimer's disease. Also, GFAP, a good sensitive biomarker, but poor specificity because people with traumatic brain injuries also have a very elevated GFAP level. Now, going back to this kind of detection threshold of all the biomarkers, I place p-tau 217 plasma just after the A beta 42 CSF in plasma. I think you can detect it very, very early, and it tracks very well with amyloid plaques. They've done it against amyloid PET scans, and p-tau 217 tracks very well, which is why a lot of people use it. There are drawbacks to it, though. So that's why I do not use plasma AD biomarkers at this time. I'm sure that will change over the next couple of years, and I want to touch base on that just really quickly. So there are analytic sensitivity issues. The sensitivity is great, but I think there are other techniques that might be more sensitive. So something called a new LISA, which is 10 times more sensitive than immunoassays at this time, might make it even more sensitive to pick up Alzheimer's disease. There's a lack of standardization. So what I mean by that is there are wide reference ranges depending on what platform you use. So LabCorp has a different one than Lucent than it does with Fuji Rebio. So you have to be aware of where the results are coming from and what references they use. It's also institution dependent. So at different Alzheimer's disease research centers, they run all the p-tau 217s, and what they see is that there are different reference values for each center. So that's a big problem for us, even when we're using all the same platform. Now, cost is very big right now. Some of the plasma tests actually cost more than the CSF at this time. So I think for these reasons, I'm still holding off on using plasma biomarkers to diagnose Alzheimer's disease routinely in the clinic. There's a lot of continued heterogeneity in plasma biomarkers because all of these blood biomarkers will increase with age. We know p-tau 217 does, GFAP, NFL. These are well documented to increase only with age, which is a big issue for us. There's possible sex differences as well. I think total tau might be higher in women, but this has to be verified with additional studies. BMI, so a higher BMI increases p-tau 217 falsely. So you have to be aware of that as well. And the big one for me is comorbid conditions. So shown here in this kind of forest plot, you can see that CKD for p-tau 217 and 217 and 181 is falsely elevated with these biomarkers just because of CKD alone. Now, we can use a ratio to kind of minimize that, but that is a big problem for plasma p-tau 217. Stroke, MI, hypertension also falsely elevates plasma p-tau 217, making these results much more difficult to interpret. So I would be very careful about getting these results on every single person, especially with our elderly population with multiple comorbid conditions. Now, we know race and ethnicity is also a big issue, which needs to be further studied too. Now, when do you order these blood-based biomarkers to test for Alzheimer's disease? The first thing is the patient has to have a cognitive complaint. You cannot test patients with blood-based biomarkers that are asymptomatic. Insurances just won't cover it at this time. Objective testing has to be abnormal. So a SLUMS, MoCA, MMSE, it has to be abnormal as well. And then you can go ahead and test with whatever platform you want or company that you would like. There's a huge list of them here. Fujirebio just got FDA approved within the last month as well. So it is out there. There's no question. I see it in the clinic. People refer to my clinic quite frequently with plasma ATN plasma profiles is what they call it from LabCorp. And so just be aware of what is out there, how to interpret it, and when to send to me and anyone at Duke. In terms of treatments, though, so there's a lot of cholinesterase inhibitors and NMDA receptor antagonists. So donepezil, rivastigmine, galantamine, these are all the traditional cholinesterase inhibitors that increase acetylcholine in the brain, which is known to be very low in Alzheimer's disease. Memantine, otherwise known as Namenda, is the NMDA receptor antagonist, and that is also found to be minimally helpful. I don't use that very commonly. What I wanted to add on here is not part of these categories is the anti-amyloid therapies, AATs. Lecanemab and donanemab we now offer at Duke as well. And so a lot of patients are very excited about trying to start these, but it does take a lot of heavy lifting to get started at institutions. There's a lot of barriers to it. In terms of social concerns, though, for Alzheimer's disease, driving is a big one. At least once a week, I have to tell patients who I diagnose with dementia, it's not legal in North Carolina to drive with dementia. So I usually ask them to stop. If they're reluctant, I have them go do an OT driving safety evaluation for more objective evidence. And sometimes that still doesn't work, and I have to report them to the DMV. I had a patient who drove through the front of a fast food restaurant, even though I told that person not to drive anymore. So it can be very dangerous, you know, so just be aware of that. Living alone is another big one. Because of the lack of insight, they feel they can still do everything, but they forget to eat, they leave the stovetop on, they can get themselves into trouble pretty quickly. And then, of course, getting lost, you know, that's a big one. Unfortunately, I see that on the news every now and again where an elderly person diagnosed with dementia is not found. And so that's, I usually tell, you know, loved ones that a smartwatch with cellular connectivity or even a life alert is probably the best option. And then avoid unnecessary testing. You know, what I would say to that is, you know, have that medical ID bracelet or that medical ID card that says they have a neurodegenerative condition to prevent that stroke alert or unnecessary hospitalizations. Now, when to refer to the Duke Memory Disorders Clinic, number one is clarification of the diagnosis. If you're suspecting frontotemporal dementia or some sort of Parkinsonian syndrome, they have one or two elements, but it could be one, could be Alzheimer's disease as well. Feel free to refer them down to us, and we have the biomarkers that can really help kind of distinguish all of that. Further biomarker testing, I think if you're trying to determine, does this person have BVFTD or early onset Alzheimer's disease, that's the perfect time to kind of refer to us, and we'll do those biomarkers to distinguish between the two. If they have interest in anti-amyloid therapies, we have a pretty big group now that is able to handle a lot of those requests as well. And then interest, if they're interested in enrolling into clinical trials. So right now we're trying to offer clinical trials throughout the entire spectrum, from normal cognition to early, very mild dementia. We don't have anything with moderate or severe dementias, so unfortunately, those clinical trials are few and far between. But anyone with normal cognition, subjective mild cognitive impairment, or early stages of dementia, we're happy to talk to them about clinical trials as well. So that is it.
Sorry. You
Oh,
have
yeah,
you have a chat. You want me to read it or can you see it?
Yeah, please. I mean, I just finished, so that's perfect timing.
It says, at what stage of dementia evaluation should the clinician consider or proceed to neuropsychological testing?
So neuropsychological, like UCSF was a very big center for neuropsychological testing. But I think for me, my practice has changed significantly with all of these biomarkers now. Neuropsychological testing can be helpful at times. I think the biomarkers are more helpful in determining the biology of the disease, because the neuropsych testing won't help determine if someone qualifies for anti-amyloid therapies. The biomarkers will. So the neuropsych testing that I do is typically the MoCA MMSE slums, and that is enough for me to determine, does this person fulfill dementia criteria or not? So formal neuropsych testing for me is not a common practice anymore.
I have
Dr.
another one.
Oh, go ahead.
Could severe depression mimic early dementia symptoms?
But can you repeat that?
Yeah, the
Depression?
question is, could severe depression mimic early dementia symptoms?
Absolutely. It's something called pseudodementia, and that's something we're always screening for with various scales that we use, FAQ, PHI, all these other ones that we use to determine, do they have severe depression or not. I'm always looking for treatable causes of cognitive changes first, medications, do they have sleep apnea? Those are common ones. And then, of course, any psychiatric illnesses. I can't say that they have a neurodegenerative condition if they have an active psychiatric syndrome going on. So,
Go ahead, Dr. Pradhan.
Yes, good evening. Thank you very much, Dr. Liu.
sure.
And it was so good to see Dr. Waltz too. In the meantime, I'm a primary care doc, internist, been in practice for a little bit. So the question is, in an everyday practice with the aging patient population, a lot of people coming with people living in a single home alone and have those descriptions described, living alone, leaving the countertop on. At what point in time, when you do the neuropsychiatric test, i.e., MoCA versus MMSE, which one you prefer? And then second question, I think you answered most of them, plasma study versus CSF. At what point in time, okay, send you your way or Dr. Wall's way?
Yeah, absolutely. So what I would probably do is the MMSE. MMSE is a little easier for patients, and the MMSE will qualify them for anti-amyloid therapies. I believe you have to have, I think, a 22 or above on the MMSE to qualify for anti-amyloid therapies. So that's one. Number two is from your, I think plasma-based biomarkers for Alzheimer's disease is perfect for your practice. If they're coming in with memory complaints or language complaints, and you're suspecting Alzheimer's disease and they score poorly on the screening test, that's when you get the plasma test. If it's positive, you can refer to us. I won't stop there. I will always get a confirmation test with CSF or amyloid PET scan to determine, do they have it or not? because those tests will then qualify them for anti-amyloid therapies if we catch them in the early disease states. And I think that's the point of emphasis I want to kind of talk to primary care and geriatricians about. The earlier we can see them, the more options they have. If they like in the Asian population, in my population, people come in very, very late in the disease state. So we're to the point where they require help with activities of daily living. They can't toilet, they can't shower, and then there's no other options in terms of treatment. So,
Thank you.
sure.
Dr. Liu, I was just wondering, this is Dr. Walsh. You didn't mention anything, but with Billy Joel and in the news, I've had some people calling it, do I have Alzheimer's or do I have NPH? Would you want to make a comment about that?
Oh my goodness. So I think it's almost as if I've paid you to say that, because I actually run an NPH clinic with my colleague in neurosurgery. So because there's so much overlap, the epidemiology of NPH is usually early 70s, 72, very similar to Alzheimer's disease. So my colleague and I, we do an NPH evaluation that's 2.5 hours. So we do a motor evaluation, we do a spinal tap for Alzheimer's disease biomarkers, we do a skin biopsy for Parkinson's disease, because that presentation is very similar to NPH, and then we can determine, do they qualify for a shunt for NPH or not, or is this just Alzheimer's disease or Parkinson's disease? And what we're seeing is about 20% of the people from the NPH clinic have a positive skin biopsy for alpha-synuclein, and the vast majority of them have at least one biomarker for Alzheimer's disease. So it's usually a mixed picture, but those people that respond very well to the what we call a tap test or a high volume spinal tap, they have done very well with the VP shunt. So happy to see that population as well. I see them at the Raleigh clinic, but my neurosurgery colleague sees them in Durham.
Okay,
I
thank
have
you.
a couple more questions in the chat.
Sure.
If there's a known FH of AD, are there
Mhm.
lifestyle preventable measures?
Absolutely. So, wonderful question. I always tell patients kind of three major things, cognitive activity. So, the worst thing they can do is just watch TV all day and do nothing. I want them to do something that they enjoy that is new to them, learning a new language, cooking a new dish, getting out into the garden, remaining cognitively active, because that will engage different brain networks that haven't been engaged before. That's number one. Number two is physical activity. All physicians want people to exercise, but I tell patients that there are two small molecules that are released in the brain for brain health when people exercise. So one that promotes the birth of new neurons, and another one that helps people focus a little more. So if you've ever done a really strenuous exercise, afterwards everything seems to be very focused. There's that small molecule that's released in the brain. So that's why I tell people to stay cognitively active or physically active, excuse me. Last one is the diet. A lot of literature with Mediterranean diets. I'm sure the geriatricians and the PCPs know this as well. But I'm very careful, and I tell them that the Mediterranean diet kind of stabilizes their cognition. It does not improve anything, but it helps kind of slow the process down, if you will. So that's what I recommend for people with a family history, and then there's many clinical trials with people with a family history as well. Our Alzheimer's Disease Research Center is one of them for sure. So
I see we got a hand raised. You can go ahead with your question.
And Dr. Mazzaretti, please ask your question. There's a hand up and no question being asked.
I
All
guess
right,
maybe
I
on
have
mute.
another one in the
Okay.
chat.
Go ahead.
This one is, how do you encourage someone you suspect has early dementia to seek follow-up if they don't have the insight to see there is a problem? For example, a family member.
Yeah, so it's a very common problem. And what I would do is say I would engage the family members to talk to them. Sometimes you just being very frank with them and showing them objective data, which is why I do more biomarker data. If they don't feel like they have a memory issue, but their amyloid PET is positive, or their cerebral spinal fluid shows fulminant Alzheimer's disease pathology, they're much more likely to understand that. So that's could be another reason for plasma too, to show them, these initial screenings are positive and suggestive of Alzheimer's disease. So.
Dr. Bazzaretti, are you there?
If you are, I think you're muted, Dr. Bazzaretti.
I
Well,
have
Dr.
one, I'm sorry, I have one request. I have a couple of people signed in that I don't know who you are. So if you signed in as just the name Frank or just the letter D, if you could I'll put your email address in the chat so that I can give you credit for attending and send you the eval. That would be wonderful.
Mhm.
Yeah, Dr. Lou, let me ask Dr. Moore, let me ask you one other question.
So,
There's lots of, if you will, public information about now being able to treat amyloid of the heart. You see it in the popular press, if you will.
sure.
Is there a connection between heart amyloid disorders and brain amyloid disorders? Does one screen for the brain if you have the heart disease? So,
Yeah, no, I don't think there's a correlation there. I think it's a different form from what I can tell you. I don't know very much about the amyloid of the heart forms though, because I know, the liver can accumulate it as well, but I have not come across literature that says these anti-amyloids remove it from everywhere. A big problem with these anti-amyloids is that it really shrinks the brain volume. And so I'm concerned that it might actually do the same with other organs as well. So it all
yeah,
depends on the confirmation.
it's interesting because I think for many of us that went to medical school a few years ago, amyloid was just presented as a complication of myeloma and dysproteinemias, that you basically had all your short or your light and heavy chains overproducing. And in some patients, they sort of all clumped together in a very simplistic approach, and you had these amyloid patients. So I
Mhm.
think we're really learning more
Yeah.
about the whole, if you will, dysproteinemic syndromes throughout the body. And everything just doesn't fit in a box like we once thought they would.
Right. I think the crosstalk between body systems is an important question to answer for sure. Thank you.
Yeah, and we've had a couple of things in the chat about, this has a lot of my information. We are recording this evening's program, and the ones of you who've asked for this, will send you a link where you can go and listen to it again. We're glad to do that. And it may be first of the week where we get the email out to you, but we will certainly do that, and it's readily available.
So Dr. Bazzaretti wanted me to
Yes,
unmute, but did you get unmuted?
yes, ma'am. Yeah, I could find
Okay.
it now. Yeah, thank you. My question is regarding management and the medications that we use for dementias. We often tend to use multiple medications, on these poor elderly folks. We dump like anticholinergics and Nemenda and antipsychotics and, along with many more medications. When do you actually consider stopping anticholinergics or Nemenda? Is there any role for the combination?
Yeah, no, it's I commonly do that. It's a wonderful question. I do that in clinic. When there are really 7 stages of Alzheimer's disease, so I think MCI is stage 3, early stages of dementia is 4, moderate is 5, 6 is advanced. When people start hitting the moderate to advanced stages, stage 5 or 6, that's when I start taking off the the cholinesterase inhibitors and the NMD receptor antagonists, because there's very little to gain in terms of cognitive function, and then there's a higher risk of the side effects from bradycardia, et cetera. So that is usually what I do from my perspective. But with these new anti-amyloids, I tell them once they started, they can't come off of it. Now, there could be a scenario where, similar to colonoscopies, where after the age of 75 or 80, they stop it. I think anti-amyloids after the age of 80, 85, something like that might be a good compromise too, because amyloid takes so long to accumulate anyways, to start, accumulating the tau protein. So I think that's still kind of to be figured out, but that's how I see these medications and how to pull them off. In terms of the antipsychotics, though, I think if they still have the behaviors, I think you still have to always keep them on.
I'll
Okay,
ask one.
Dr.
I'll ask one last quick question, if you don't mind. Just the biochemistry. When you talk about the p-tau 217, 181, 231, is that just those amino acids are phosphorylated?
Right. That's exactly right. So we have shown that biochemically, these phosphorylation sites correlate with Alzheimer's disease very specifically. So you'll see a whole bunch of other numbers coming down the pipeline because everyone wants to now try to beat 217. So that's what the number represents. So
Okay.
181 is still a very good biomarker. Please don't disregard that one. That one is still in use, and I think it's going to be like the classic iPhone, if you will. It is revolutionary. It's still really good, but it's just not as up to date as the newest one. That's all. So,
Thank you.
yeah, sure.
Thank you very much, Dr. Liu.
You're very welcome. So,
Okay, well, and thanks to Dr. Walsh for moderating this. Dr. Liu, you did a great job. And I'm so grateful for all the comments and questions and so forth. That it makes us feel good when we do programs and we're providing information that seemingly really are helping you in your daily practice. Let me remind you that we'll send out reminders about the July programs, the program on measles, and then, if you will, patient resources in our communities. We are very grateful for you to participate with us this evening. As I remind our residents when I have the privilege of speaking with and to them, please be careful out there, and we hope to see you back in our next program. Take care. Good evening. Bye-bye.
thank you. Bye-bye.